Okay, to start, I just want to quickly say that we are proudly supported by the following sponsors on the screen. Without their support and their contributions, we wouldn't be able to hold all this programming, such as these educational webinars. And today, first I'm going to introduce Migraine Canada. I will then introduce our keynote speaker, Dr. Elizabeth Leroux, and she will have her vestibular migraine presentation. And after that, we'll have our question and answer session, part of the evening. So Migraine Canada, who we are a national nonprofit, federally registered charity supporting all Canadians living with migraine and headache disorders. Our mission is to improve the lives of Canadians with migraine and other headache disorders through advocacy, awareness, education, research, and support, our 5 pillars. Watch out for our final 2023 webinar, which will be December 4th. It's going to be on the topic of migraine in children and teens. Our vestibular migraine webinar is tonight. And if you haven't already, most of you probably are a part of our community, but you can join anytime to receive our newsletters, any notifications of new resources and our events. Check out our advocacy page where we have form letter templates and other great resources to advocate for better care and coverage. And you can also check out our resource library, available in both French and English. These are 2-page resources on what migraine is and different ways to treat migraine. So before we begin, we do need to make it clear that this webinar provides information and not medical advice. Please note that the information presented and discussed might not apply to your own medical situation, and always discuss medical treatments with your own healthcare provider who knows your medical history. So Dr. Elizabeth Leroux is our keynote speaker tonight. We're very happy that she's joining us again. She is a neurologist and headache specialist, currently practicing at the Brunswick Medical Center, Leroux, and she is a faculty lecturer for McGill's Neurology Department. Dr. Leroux completed her neurology training at University of Montreal and her headache fellowship in Paris, France. She directed the headache clinic of Centre Hospitalier de l'Université de Montréal between 2010 and 2016, followed by the CHAMP multidisciplinary program of the University of Calgary from 2017 to 2019. Dr. Leroux is past president of the Canadian Headache Society, the founder of Migraine Quebec, and founder of chair of Migraine Canada. Dr. Leroux is a well-known speaker for all audiences interested in learning about headache medicine and science. She's passionate about education and advocacy for headache disorders, and her particular interests include multidisciplinary and holistic approaches, the impact of migraine in the workplace, vestibular migraine, and cluster headache. And with that, I'm going to turn it over to Dr. Leroux for her presentation.
So thank you everyone for attending this webinar. Welcome. It's an evening in November. I'm sure you're all busy and all, so thank you for joining us tonight. I want to thank you also for your support of Migraine Canada and your feedback to us, and also sharing and talking about this, because as the chair of Migraine Canada, I really want this organization to grow. I started it to serve people with migraine and to break migraine stigma. So I really hope that we are helping you or the people that you care about in any way that we can. And we're growing, we're learning. So thank you for feedback, sharing, and being part of our community. So tonight we talk about vestibular migraine. The image in the background is a beautiful lake. I am a fan of canoe camping, and those are still waters, you know, no storm, no instability, no travel sickness ahead. And so that's what we all wish for, this nice quietness. But vestibular migraine is anything but that. And so I think it's very important that we talk about it tonight. So I will see if I can move now my slides. I do present my disclosure information. This is what I show when I present to scientific audiences. because I do receive an honoraria from mostly the pharmaceutical industry as a speaker, consultant, or board member. Everything is off-label for vestibular migraine, so any comment I will make on treatments or medications here is entirely my opinion and hopefully supported by evidence. Okay, so I will start by saying that my interest in vestibular migraine and vestibular problems in general is because I have personally experienced a lot of it. And I will disclose this with you tonight, that I had labyrinthitis as a kid. I remember lying in bed with severe vertigo and vomiting for actually close to 2 weeks. I also had severe travel sickness as a kid, throwing up on cars. I had an episode of BPPV, which I will talk about a bit later, just a few years past. I do live with episodic migraine with and also without aura. I have a visual intolerance up to this day, meaning, for example, that I cannot watch movies that are shot, with instability and action zones. And sometimes I watch a screen and I look around and everybody seems to be enjoying themselves, but I just cannot look at all those moving images. And this is something I can see that I'm a bit abnormal because everybody else seems to be okay except me. I had 2 attacks of severe vertigo with nystagmus, so kind of shaky movement of the eyes, and vomiting without headache that I think are probably vestibular migraine, but as you will see, do not completely fit the criteria for vestibular migraine. And I also had an attack of migraine 2 years ago after a day of kayaking, where I worked a lot with my shoulders. And the next day I woke up with a bad headache with neck pain, shoulder pain, and severe dizziness that I kind of thought was linked to my neck and to my overall migraine story. So I'm telling you this because when I meet patients with vestibular problems, whatever the diagnosis is, I tell them that they do not have to convince me that those symptoms exist. So they do not have to convince me how disabling those sensations of all kinds, vertigo, vestibular intolerance, visual intolerance, can be. And so I share that with you so you know that I really care about those symptoms and those problems, whatever the diagnosis is. The other thing that I want to start with is that there are no simple answers in this field. I do go on different conferences. I attend congresses. I am part of the special interest group of the American Headache Society on vestibular migraine and disorders. And there's still a lot that is in discussion, even among experts. So it is normal that some doctors don't know about those things, that some doctors may disagree about those things, and that you might feel a little bit confused about all of this because it is not set in stone. There's some degree of uncertainty and definitions that are tentative, that might be consensus from experts at present time, but not something that will always remain in that state. And that's something that is always a bit, we think that medicine is just like, there's one truth, and we wish it would be the case. But in this field in particular, there is a lot of questions that are still open, but I will say that there's more and more research, more and more publications about it, and more presence in conferences and scientific meetings of vestibular migraine, which was not the case 10 years ago when I started to get interested into it. So what will I cover during the following talk? We'll talk about anatomy and the meaning of the word vestibular. We'll talk about the symptoms. We'll talk about a few diseases that can cause vestibular symptoms and may coexist with migraine. We will define, of course, vestibular migraine, and then illustrate different scenarios that might lead to symptoms, and then talk about some tests and very practical comments about different treatments. I will also make a little note about PPPD, so persistent postural perceptual dizziness, a diagnosis that may coexist with numerous vestibular issues. So let's get started. So what does vestibular mean, right? So vestibular relates to the vestibular organs in our inner ear. And you can see here inside the ear, there are two sets of organs. There is the cochlea. The cochlea looks like a little snail. And this is the organ for hearing. And I'm not going to talk about it tonight. But what you see on the right side with all what we call the semicircular canals that are little tubes filled with liquids that ensure our sense of posture so the semicircular canals are the canals for our balance. And you can see that nature is beautifully done because they are oriented kind of 90 degrees apart in all directions. And they tell our brain where our head is going, depending on how the liquid flows, you know. So this is really a biomechanic gravity influence system that will relate to our brain how our head is moving in direction and also in speed. So is it rotating in that direction very fast or just bending in the front very slowly, for example? And it does that through quite a complicated system, and I will not go into great depth about this, but I want to show you how much we know about this system in what we call the different receptor organs, right? So we have those tiny, tiny little cells with little fine hairs that are moving in the liquid, and then the movement of the air, the hairs are transmitted in electricity in the nerve fiber. Isn't that magical? So depending how we move our head, then those little hairs will feel and then transmit into an electrical signal that then will be put together by the brain and then transferred to your consciousness to tell you information. So this is something that we know and we understand, but we cannot necessarily see in that degree of detail in a person. This is more from anatomy. But when we see a living human being, we cannot, of course, examine this in this degree of detail. And then once we have the electric signal, have to be transferred to the brain and interpreted. And they then interact with a lot of other things. For example, what we see with our eyes, what we feel with our feet, and what we feel, of course, also with our neck. So there's a lot of things kind of talking together, and everything has to align so we have a bit of a sense of position in the air. So here is illustrated in this image that to stand stable and to feel stable when we walk around, for example, well, then we have to use our ears, our eyes, our neck, but also all our spinal cord down to our feet and legs, because our legs are also constantly telling us where we are. All of this is modulated by other organs, and I'm not going to go into great depth about those neurological terms, but for example, the cerebellum is one part of the brain that will modulate all our movements for precision and coordination. And it also plays a role into our gait and our standing state. So there's a lot of different organs that interact with the vestibular system. So, and next, so this is a bit more detail about this. The vestibular system will play many roles because this information about the position of our head then serves different function. For example, well, it's very important to decide where our eyes are directed depending on our intention. If I want to catch something that's moving, or if I want to study or to read, if I want to drive, every time that we use our eyes, the vestibular system is in action, because it will help our eyes to focus on the target. And this can depend a lot on, you know, what is moving, where we're focusing, far, near, etc. So the eyes are something. The balance we talked about. The spatial orientation, you know, where we are globally in 3D at every time. And then the autonomic part. Autonomic parts talks about what will mediate, for example, our blood pressure, our heart rate, all kinds of other functions in our body. So our vestibular system is interacting at every moment with all of those systems, and you can see how this will relate to the symptoms that we will describe in a moment. Sometimes you will hear a lot about neurologists or ENT talking about peripheral versus central. And this is something that we use all the time in neurology. And I think we can use a bit of a computer analogy. So the brain, central, is like the computer. It's where everything is put together, interpreted, and analyzed. So this is what we mean by central. And so this concerns everything apart from the actual peripheral organ. So you could say that peripheral is like whatever is plugged into your computer. A printer, maybe a fax machine, maybe a scanner, maybe some other video game. So all the organs that are plugged into the system, like the peripheral vestibular organs, are what we call peripheral. The minute that it enters the brain, then we call it central. And in the central, there are many different bits and bytes and programs, if you wish, of the computer. So when we see a person with vestibular symptoms, and I'll get that in a moment, we want to try to understand if they are from the peripheral system or if they are more central. So for example, anyway, so when we talk about peripheral vestibular system, the symptoms are usually the very clear rotatory vertigo, a spinning rotation, something that is spinning and turning. That is what happens when the two peripheral organs are not in full balance. Then when we go more centrally, then it can become a little bit more difficult to describe. For example, thinking about those eye connections, having difficulty focusing the vision, sensitivity to moving things, like I was describing me in the movie theater, different patterns, for example. And then there's all this question about the sensitivity of someone walking. So that's the connection with the cerebellum. So feeling unstable, swaying, feeling pushed. All of this is not directly peripheral. It's not only the vestibular system. It's the vestibular system in its relationships with other systems. Okay. Then vestibular sensations, let's say the vertigo, the swaying, they may come with other symptoms. But these symptoms are not always caused by vestibular issues. So for example, if you have a lot of vertigo, then it will activate strong reactions. For example, the stress response, okay? You will feel faint, sweaty, your heart will race. We talked about this autonomic reaction, like adrenaline reaction, stress response. This can be extremely disabling, very powerful, but you can feel those things even if you don't have a vestibular symptoms. There are a ton of other reasons why you might feel like this. Nausea and vomiting come a lot with vestibular reactions, but they can come with other things. For example, just plain migraine with no vestibular symptoms. And then the vestibular issues can also come with brain fog, difficulty to focus, difficulty walking. And all of this can also occur without any vestibular dysfunction. And then, of course, feeling like this will raise anxiety, and anxiety will increase the vestibular sensation, because anxiety usually just is a dimmer on our sensations. And if you are very anxious, everything will be heightened, more powerful. You will feel everything bigger than it is, whether it is an emotion, an expectation, or a bodily sensation. So those vestibular sensations are accompanied by other responses that can be also quite disabling. But sometimes we might feel all of those symptoms with no vestibular issue whatsoever. But then people might feel that they are dizzy because they feel like that, but they have no vestibular issue. So feeling dizzy, when I was in med school, I remember distinctly, it's one of the things that is the most difficult to question when you meet a patient. It's one of the most difficult symptoms to describe for a person. There's actually research showing that people will change their description over time. So for example, if you take a same patient in the emergency with a complaint of dizziness, Well, the resident can come and take a very good history and saying, yes, it was a spinning, rotatory vertigo. And then the staff neurologist come and the person, no, all the history finally changes. And this is very common. So there's different types of so-called dizziness, the vertigo that is spinning, the disequilibrium, which is feeling kind of wobbly and off balance, lightheadedness, it's kind of woozy, brain fog, maybe this disconnection, and then this kind of autonomic feeling that I mentioned, feeling faint, feeling maybe sweaty, or you're going to lose consciousness. And it's okay not to be sure, because as I told you, all those symptoms come together, and sometimes you can have everything, or you can have just part of it, and it can change over time as well. So you will see sometimes that doctors might be a bit frustrated that they don't understand what you mean. And even if you try your best, another thing that you will see when you meet doctors, especially in the emergency department, is that they will try to push you in one category. They will tell you, is it spinning? Is it rotating? Because they would like to understand if it's peripheral or central, right? They try to make it clear, but sometimes it is not clear. That's just the hard truth with this system. All right, now in the next 4 slides, I will present to you some other diseases that will cause vestibular symptoms. And I swear I will get to vestibular migraine, but I think we need to talk about other diseases first, and you will see why. The first is Meniere's disease. So Meniere's disease is a disorder of the whole vestibular system and also the cochlear system, so the auditory system. As you can see on the image below, it is a problem where all those canals that are filled with liquid, well, the cavity becomes somehow distended. We call that hydrops, right? So it's like it's too swollen. It's under pressure, like those little canals. They're very sensitive. And all of this leads to loss of hearing, violent attacks of rotatory vertigo, usually with vomiting that can last usually more than 30 minutes, can be hours. And it evolves over years, and sometimes people will completely lose their audition on one side. So this is not an easy disease to diagnose. It will take an ENT to do it. But this is a very serious condition, though now we have more and more treatments for it. BPPV, that I mentioned as well, is a disorder that's completely different. It's not Meniere's disease. And this causes, so it's a problem of a displacement of the little, I'll call them the little crystals because people understand that very well. We call them in medicus otoconia. So those are the little rocks, like really, that are floating in the liquid. And then they go in the wrong place. It's like they are going to push on those little hairs that we talked about, and they will send very wrong signals of where your head is. So when you will, for example, turn your head in a certain position, typically in your bed in a certain side, then everything will start to spin until the little crystals are kind of like quieted down. And then you feel okay until you move your head again, and then it's going to spin again for a few minutes. This doesn't come with usually attacks that last hours or any hearing loss. And it can be diagnosed now very well in vestibular physio or by a doctor by different maneuvers of the head. And then it can be also treated by maneuvers of the head in the vast majority of times. So that's why we call it benign, because usually it's not something that leads to disability or long-term issues. And paroxysmal, because it kind of starts and stops, and positional. Then we have labyrinthitis. Labyrinthitis is something quite elusive. Roughly, it is a viral inflammation of the ear. And it is like any virus, like the one I have right now, it comes and goes. And it starts like a bit suddenly. People will have sometimes hearing loss, a lot of dizziness, a lot of vertigo, nausea, vomiting, sometimes pain in the ear as well. And then it may last a few days, a few weeks, it will resolve. There is actually no final diagnostic test, but if you do testing, you will find that both organs are not the same. One is actually not functioning right. So this is something that can be diagnosed, but it takes a bit of special testing, which they do not have in the emergency department. So I will say a lot of people with vestibular migraine are thought to have an episode of labyrinthitis because they went to an emerge, and that's what the ER people will diagnose when they have excluded other things, right? They will say, oh, it's a labyrinthitis because, you know, that's the most common thing probably in the emergency setting. And then the last thing that can cause vertigo and dizziness, but not the least, is stroke. But of course, stroke, it's something very sudden. It occurs usually one time and that's it. And it comes with other problems usually. It's not only being dizzy, it will be with double vision, different things, for example, numbness, swallowing difficulties. I want to be very careful here because stroke, first, is a serious condition, and I don't want to make you feel like there's a unique picture of what we call a brainstem stroke, because it's a very complex thing. Even neurology residents struggle to learn about brainstem stroke. So my whole point here is that if you never had a severe episode of dizziness or vertigo in your life and you have one, it's okay to go to the emergency department and to be worked up for it in case, you know, it could be a stroke. So I want to be very prudent here about this one. So why did I present all of those diseases and I haven't still said a word about vestibular migraine? It's because migraine is actually comorbid. It fares along all of those things. So people with migraine have more chance of having BPPV, more risk of having Meniere's. They have, I don't think that they have more risk of having labyrinthitis. They have a bit more risk of having stroke, though usually not brainstem stroke. They have also more risk of having motion sickness, because motion sickness is like this sensitivity to vestibular perception. And all of this is 2 to 3 to 5 times more frequent. So that means that, like many other problems of the brain, the migrainous brain can be triggered, influenced by other diseases. And that's true for the sinuses, that's true for the neck, that's true for the mental health issues, that's true for the TMJ, like the jaw problems, bruxism, people having grinding issues. All of this, I call this the ping pong of the brain. So the migraine brain will just react to whatever you throw at it, right? So if you throw sleep apnea at it, well, there's going to be more migraine and more symptoms, right? So that's true as well for any vestibular issues. So that means that if you live with migraine and then you develop Meniere's disease, well, of course, if you start having Meniere's disease, you might start having more migraine because you're going to have those attacks, maybe some stress related to it, lack of sleep, vomiting, dehydration. So there's this influence of vestibular diseases triggering migraine attacks. So it might be that if you live with migraine and you have vestibular issues, you do not have vestibular migraine, you might have another diagnosis that has to be diagnosed by a proper person, may that be an ENT or a neurologist, and treated accordingly. It might also mean that if you have BPPV and you live with migraine, well, maybe the BPPV will be a little bit more intense and you will not adapt to it, because people with migraine do not habituate very well to sensory stuff, right? They see more intensely. They cannot turn down, the level of the sounds, of the light. Their brain is just, our brain, I have migraine, is just not wired that way. And that's true also for vestibular problems. So for example, when I had my BPPV, I knew it was BPPV. I diagnosed myself and I treated myself in my living room. But then I was not completely symptom-free in between episodes, because I always felt a little bit dizzy, even after this retitory phase, because my migrainous brain was just, and I was already sensitive. So all of this took more time to resolve than it would have in someone without migraine. So the migraine brain becomes sensitized and does not habituate, because either we have a lower threshold, so we perceive very mild sensations, or there's a lack of brakes, inhibition. So we have an inability to ignore or downplay whatever sensations that life throws at us. And in that sense, migraine can lead to increased and persistent vestibular sensations caused by another disease. So now we come to the core of things. Can migraine itself, without any other things, cause vestibular symptoms? The answer is yes, it can. There's a lot of different causes or different systems and different pathophysiology hypotheses that can explain why a person with migraine could have vestibular sensations with no other condition at all. And here, I want to invite you to think like a neurologist, which is we think by zone, by stage, by floor, if you wish. So we can imagine at least 5 different things, 5 different parts of the brain that might be involved in vestibular migraine, from the cortex, so this is the outer part of the brain, to the thalamus, which is a bit of a regulating center, to the nuclei, to the cerebellum, to the organs. And then we can think it a different way. We could say maybe it's a matter of neurotransmitters. So, a chemistry way. Is it serotonin? Is it dopamine? Is it acetylcholine? We can talk about it until tomorrow morning. Okay, so there are a lot of ways linking the vestibular system with the whole brain. And all of those have also actually been supported by different research pieces. For example, showing abnormal things going on in the cortex, in the thalamus. Another hypothesis, could a vestibular sensation be an aura? So maybe some people with vestibular migraine have auras that are vestibular. So there's a lot of potential reasons and a lot of potential connections. And just for fun, prepare. Those are more connections, just showing all the links between the pain systems of migraine and the vestibular system. So there's no end of potential links between the vestibular ways and the migraine pathophysiology. So, and believe me, a lot of doctors don't know about all of this because just nobody told them. It was not part of their training, and it's just damn complicated. In theory, there are many brain mechanisms that could lead to vestibular symptoms in migraine. But the big problem is there is no way to check that in practice yet, okay? I, to this day, have zero way. There's no biomarker for migraine, meaning that there is no kind of official test that I can run on someone in my clinic, in research centers and other thing, to prove that they have migraine. There's no way. So, and we have no way to study the vestibular system, like just clinically in our practice. So you can imagine that having headache, that's very common, and then dizziness, that's also very common, and very difficult to question. Well, they're both very common symptoms, and this is partly why doctors are reluctant to link migraine and dizziness as a diagnosis historically. But what are the criteria? So here we are. Okay, there's been a lot of different terms used for migraines, for what we call now vestibular migraine. There was something called MARD, migraine-associated related dizziness, migraine vestibulopathy, migrainous vertigo. All of those terms have been used in the past. Now we use vestibular migraine. So it takes roughly at least 5 episodes, and you need to have a history of migraine. And I'll make one point. You have to have headaches, okay? You cannot have no history of headache and have vestibular migraine. This is not a thing. Then the vestibular symptoms have to be there, lasting between 5 minutes and 72 hours. And then a half of those episodes are supposed to be associated with at least one of 3 migrainous features. So a headache with different characteristics of migraine, photo and phonophobia, or visual aura. So this is where it's getting a bit tricky, because in theory, you could have, for example, 50% of episodes with just visual aura, and you could call this a vestibular migraine. But that's not the most common scenario. So just remember those criteria are working criteria. They're not final, and they're absolutely by no means something that I expect to see set in stone for the next whatever years. But this is what we work with at present time. In addition to the symptoms that I just showed there, there's a lot of other things that people who fit those criteria also present. So they will have, for example, attacks of untriggered vertigo. They can have provoked vertigo, even by, you look at something that moves, triggers you, moving the head, triggers you, moving your body, triggers you. You can have tinnitus, which is something extremely common in the population and even more in people with migraine. You can have a feeling of having a full ear. You can have the famous osiopsia or shaky eyes, which is kind of when someone has the nystagmus, which is a term we use in neurology when the eyes are beating with a rhythmic way. Unsteadiness, lightheadedness. Alice in Wonderland is something a bit more rare that is a distortion of size, for example, or even color. So that's something that's associated. And those symptoms are very disabling. And I don't need to tell you this if you live with vestibular migraine. So this is an example where in a daily life, our vestibular system in a busy environment like a metro station, everything's moving, you are moving, people are moving, there are sounds, there are lights, and then it might overrun your brain, your sensory analysis system. And then all of this might become overwhelming and you might feel dizzy. Anxiety and other symptoms also accompany vestibular migraine. Anxiety is extremely high, and like I've explained to you, it's no surprise because those sensations can be extremely disruptive. Depression is high, insomnia is very common, brain fog, phobias, so having phobias, for example, of busy places, agoraphobia, and also what we call functional syndrome, which I will not go in detail to at present time, but this is really something that comes with the different types of mental health issues. All right. So I want to make a comment here. If those of you maybe who do not know this guy, this is Dr. Glaucom Flecken. This is a fake name for a guy who is doing videos about medicine. If you want to look him up, he's hilarious for us doctors. If you are in healthcare, you will understand those jokes. So on the left, you have the neurologist with interesting hair style and glasses. On the other side, you have the ENT. You're looking, we make fun of surgeons to be a little bit, like this, what, why, and to be very kind of physical people, but not necessarily intellectual like neurologists. Anyway, so sometimes the ENTs will refer to neurology people who have so-called chronic dizziness, but they have no history of headache, no diagnosis of migraine. And then they will say, oh, the patient is dizzy. I cannot find anything in the peripheral organ. Let's send to neurology for vestibular migraine. As I've shown you, to have a diagnosis of vestibular migraine, you need to have a diagnosis of migraine. How much migraine is not too clear. What if you had a few episodes in your teens and never again? Is that sufficient? So the typical history of vestibular migraine I'll show in a few moments, but just to be clear that there's a gazillion reasons why someone might feel dizzy with no headache, and that is not vestibular migraine. So there's many scenarios. Those histories are very long to take. So when I meet a person with a complaint of headaches and dizziness, then I have to go over the full history of migraine, with the symptoms, their duration, their frequency, whatever happened, the tests, the treatments. And then I have to do a history of the vestibular complaints. And as you've seen, there are many different types of symptoms. So to have every symptom, the duration, the frequency, what was done, the testing, and eventually the treatments. And then do they associate, right? So are they coming together? Are they linked? Or is it someone who has a history of migraine and then developed Meniere's disease, right? So I always look at impact and disability, impact on mental health, anxiety, hypervigilance, avoidance, and then, of course, all the treatments. So those are very long stories to take. And once again, sometimes Doctors do not have the time or interest or training to perform those complex histories, and it leads to sometimes a bit of just disregarding or saying, oh, vestibular migraine is not a thing. It is a thing. It is a diagnosis. It's a bit complicated. So here is a typical history that I see in my office. So it is usually, so it can be a man, of course, but let's say there's more women. In her 40s, there's something with vestibular symptoms in the 40s, right? Is it the pre-menopause, or is it hormonal, or is it having kids and parents and taking care of everybody? I don't know. But I see a lot of vestibular symptoms starting in the 40s. So she has a history of migraine. At 32, she had a so-called labyrinthitis. So she had 3 weeks of vertigo and gained its stability. Then she recovered, but then she remained sensitive to movements. But people who have labyrinthitis sometimes do remain sensitive to movements. That's documented. At 38, migraine frequency increased. That happens. At 40, she had another labyrinthitis. That was maybe a bit shorter. And since then, she has episodes of dizziness, sometimes with migraine, sometimes without, like we've seen. Doesn't have to be every episode linked with the migraine or with headache, lasting 1 or 2 days. And overall, she has some episode 20 days per month. So sometimes the migraine with or without the vertigo and the dizziness. And in between episodes, she's always very sensitive to things that are moving fast and every visual stimuli. She's cautious with driving. She has stopped dancing lessons. Her neck is very tense. And the osteopath says that she has cervical dizziness. That I would say would be a quite typical history of vestibular migraine. Now, don't get me wrong. Vestibular migraine can start at any age. It can start very young, can start older. It can come in all types of frequency, durations, and flavors, but that's something I see a lot in my office. So to illustrate this in a bit more synthetic or schematic way, so I like to have 2 lines, right? Like I said, the line of the migraine history and then the line of the vestibular history. And now I added here little starts, this labyrinthitis. Is it because you had migraine? Then you had a labyrinthitis, an inflammation of your ear. And since then, this kind of sensitized made your vestibular symptom or your vestibular system more sensitive. And then you develop migraine with vestibular symptom. That's a theory that's around, and that might be very true for some people. Then the other thing that I sprinkled there is TBI, traumatic brain injury. So we know people with concussion will develop vestibular symptoms. It's part of the concussion symptoms, feeling dizzy, brain fog, and then all the rest that I mentioned. So that sometimes will trigger also vestibular symptoms that might coexist with migraine. And then people might evolve from having occasional attacks to having those kind of chronic symptoms, chronic headache, chronic photophobia, chronic dizziness, vestibular intolerance, and always being in this kind of super sensitive state that we are familiar with. A few words about the neck. What about the neck? So a lot of people believe in cervicogenic dizziness. And cervicogenic dizziness, the idea is because our neck, and as I've shown you, the neck also tells us where our head is, at any time. So the idea is that there are some nerves in the neck that will tell us where our brain is, and that might actually lead us to feeling woozy, unstable. And we know that's possible because when we block those nerves in the neck, my patients, when I do nerve blocks, sometimes they will say, oh, I feel a little bit dizzy. So that makes sense that the neck could cause dizziness. But the current thinking of the scientific community, the Barani Society, which is the leading organization on all of this, is that cervicogenic dizziness is overdiagnosed and even scientifically uncertain. So there's a lot of websites out there from osteopath, chiropractor, claiming that they can cure, cervicogenic dizziness. I think it's absolutely okay to do everything to take care of your neck. But it's very normal that feeling dizzy will also cause neck pain and neck tension. So sometimes it's very difficult to call the chicken or the egg. So at the end of the day, my point on cervicogenic dizziness is I basically never diagnose it except in very rare condition. I just put it in the whole melting pot. I try to stabilize the neck of my patients the best I can with different techniques. And the cause, the original cause, is very rarely the neck. It's part of the problem, but it's rarely the cause. All right. So now that we have discussed quite a bit of stuff, so the definition, the anatomy, the science, other diagnoses, I will tell you at this moment, you probably know more than quite a many doctors who have no interest in vestibular migraine. So now in practice, what does that mean for you as a potential patient living with this? So first, if you live with this set of symptoms of migraine with dizziness, well, first you should see an ENT and get appropriate testing, mostly to exclude other disorders, okay? So there are many tests that can be done, not necessarily to diagnose vestibular migraine, but to exclude other things. So VNG is called a video nystagmogram. So that's where they put those funky goggles on you. And then they record your eye movements with suppressing your fixation. Means that if you don't see in front of you because of the goggles, then the eyes will kind of go around a bit more freely. And they can analyze the eye movements very precisely. So that's a very important test to test the vestibular system. Caloric testing is looking at the reflexes of the ears with cold and hot. So hot water, cold water. It's not particularly funny because it will cause vertigo and dizziness. So for people with vestibular migraine, it's usually not a fun test. SOT is the test that you see at the below part of the image, testing more about the postural reflexes and the kind of the standing function of the vestibular system. VEMPs are vestibular evoked myogenic potential. This is more to check about the relationship between the neck and the vestibular system. And then the audiogram to test hearing. So all of that can be done by a good ENT lab, but there is no specific testing for VM. And 40% of people will have fully normal vestibular testing despite meeting the clinical criteria. 60% will have some abnormality, right? It can be a bit of decreased hearing. It can be a little bit of abnormal eye movements. So there are central and peripheral. So I'm not going to go into detail about what is what, but there's a long list of different things we can look on these tests, and we can find some abnormalities. They may actually deteriorate over time in people with VM, but this is not part of the diagnostic criteria because it's not specific enough. 2, so keep an adapted diary. This is maybe not a super good example because it's not detailed enough. The diary we use in the clinic where I work with an ENT expert in Meniere's disease, and we have built a very detailed diary. We don't do that forever, where people will record, everything: the headache, the photophobia, the sonophobia, the nausea, the hearing aspect, the short dizziness, the long dizziness, the intense vertigo, and so people can just map all of this, and then we see what type of episode coalesce, together versus separate. And that helps us understanding what is going on with a particular patient. So even, having a headache diary, I'm sure some of you have done them. It takes time. It's a lot of detail. If you have vestibular migraine, it's even more detail, but it's very important. 3, a lot of people want to know about vestibular physio. Should I do it? Right. So what is vestibular physio? Vestibular physio is designed usually for people who have a peripheral problem, right? We think that vestibular migraine is mostly a central problem and that people with vestibular migraine do not habituate, right? So they have difficulty adapting. Their brain have difficulty adapting. So usually when we use vestibular physio, it's because one organ is weaker than the other. Then there is an imbalance, and we train the brain to manage this imbalance, right? So this is very good if you have a problem with an organ. But if your problem is the habituation, it's longer and more difficult to train and to use vestibular physio to improve. So there are studies showing that vestibular physio is good for vestibular migraine, but it takes more effort, more time. And of course, the exercises, which is mostly like looking and challenging your brain to adapt, are going to be difficult and disagreeable. So sometimes I will say that it's better investing in anxiety management, because at the end of the day, a lot of the disability coming from this can be mitigated if someone decreases their reaction to the vestibular symptoms. And like I told you, I've had those symptoms. I know what they are. So sometimes adding the layering, like the icing on the cake of anxiety, hyperventilation, panic, then everything is worse. So sometimes just learning simple breathing techniques and managing avoidance, managing triggers, that's very difficult, but it can be done. So sometimes I do refer more my patients actually to psychotherapy, CBT, breathing exercises, or different types of therapists than to the vestibular physio, depending. Sometimes they do both, actually. So that's very important. The problem is that a lot of my patients with VM, well, because nobody believed them for so long, and they don't want to be told they're crazy, they don't take very well the idea of seeing a therapist. So I tell them that the idea here is that they're not crazy, but they will say the therapist not to talk about their parents or their childhoods or so on. It's really about key techniques to manage the autonomic surge, the autonomic reaction of having those very disruptive feelings. All right, in that line of thought, what is triple PD? So triple PD is persistent postural perceptual dizziness. This is a relatively new thing. It does not exist. Like 10 years ago, nobody was talking about, even 5 years ago, it was not that common. Now everybody talks about it. So this is what we call a functional neurological disorder. I will not go into detail about the definition of FND. I do invite you to go on neurosymptoms.org to read about it. But roughly, triple PD is when there is an interplay between the vestibular system, but a lot of the anxiety system. And sometimes there is actually a vestibular episode. Something happened. Maybe you had labyrinthitis, for example, very easy, or maybe BPPV. And then your brain reacts by producing a lot of hypervigilance and a lot of avoidance, and by watching a lot and then producing like a constant feeling of instability that is never ending, that is always there, that fluctuates. And people develop sometimes a bit of a like weird way of standing with oscillations, walking, and everything is constant and disabling. But at the end of the day, the key issue is not vestibular. It's more into different, let's say, sometimes anxiety traits, but also sometimes just the way your brain is caught in a bad loop. It's caught in a loop where those symptoms are just there and their brain is keeping them going and going without you wanting it, of course, right? So this is what a functional neurological disorder is. And triple PD is in that family of systems. You can see here that there's usually a precipitant, then different personality traits or different pre-existing anxiety traits. And then sometimes there's also a context. So there's sometimes a context, and then all of this loops and turns can be very disabling, and it has to be addressed. Attacks may be very difficult to treat. You know this probably already if you live with this. Migraine attacks should be treated as usual with NSAIDs, triptans, Gepants, and so on. The problem I see in my clinic are the violent vertigo attacks. Those are tough. And I'll tell you, there is no, let's say, there's no magic recipes for those. I'm still shopping for it. I'm asking around, when I go to conferences and so on. So sometimes I give my patients injectable triptans, nasal sprays like Zomig, for example, gravel suppositories, because they are not, absorbed by ingestion, can be lifesavers. There's also all the other suppositories, but sometimes they're back ordered. For example, metoclopramide, prochlorperazine, or Stemetil. So anything that is not taken by mouth, obviously, can go faster and hopefully help you. Zofran, if you haven't had Zofran for nausea and you live with migraine, this is an amazing thing, very well tolerated, and often very effective. Antihistamines. So histamine plays a role, and those of you who have travel sickness, you know that we use antihistamines to prevent it. Benadryl, Reactin, sometimes can make you a bit sleepy, which can be a relief. And then, yes, I told you about anxiety. So breathing is great, but sometimes it's not, working. So sometimes I will give my patients some benzodiazepines like Ativan or clonazepam. But there is a risk of dependence, addiction, and this should be discussed carefully with your healthcare providers. There are different, neuromodulation devices that might be of interest, like Gammacore or Cephalene. And then the whole gamut of, migraine treatments that of any relief, headache, hot and cold and warm and smells, or, mint rollers and so on. But those attacks are tough. And even in my practice, I struggle to treat them. Prevention. Okay. So here you might wonder why there are all those little circles. They are buttons. I call them chemical buttons. So when I present vestibular migraine to my patients, I explain to them that the vestibular system is a bit like it's like a control panel, a very complicated control panel, because you see here this little neuron. So this is a neuron of the vestibular system, and it's very well connected. It has lots of friends. So it is really connected to every neurotransmitter you can dream of. There's a reason why so many medications can give dizziness as a side effect, right? So it means that virtually anything can modulate the vestibular system, which is a good and a bad thing. So there's a lot of preventive. So the good news is, the bad news is it's trial and error. There's no way that I can predict, or anybody can predict, what will work for you. The good news is I have seen successes with every one of those options, and good successes. So I tell my patients it is a long road of trial and error, and it's even more complicated than with migraine normal, because you have to kind of check the migraine, but also the vestibular symptoms. And if you have a vestibular disorder in addition to it, like for example, Meniere's disease, it's even more complicated. So, but it can be done and it can work. So verapamil, for example, amitriptyline or triptyline, beta blockers, pranolol, topiramate, venlafaxine. Flunarizine is an old thing that has a lot of side effects that come with it, but sometimes it's used for migraine with aura and also vestibular migraine with success. Lamotrigine is usually not used for migraine. Sometimes we use it for vestibular symptoms. Botox can work. CGRP antibodies can work. And things like gabapentin or pregabalin. So that would be gabapentin is Neurontin and Lyrica. So all of this can work, and no doctor can predict which one is going to be good for you. But it's worth trying, and you have to carefully look at your symptoms and see if they work. So additional resources. I have two of them. I think some of you might know already, the dizzycook.com. There's a lot of recipes in there, which I'm not too sure are going to be the key to your migraine management. I'm sure they're delicious, but there is actually a vestibular migraine guide there with a lot of comments about vestibular migraine, because this person has vestibular migraine. And then the vertigodoctor.com is an interesting website where they have therapy. So they have, I mentioned about vestibular physio. So Vestibular Group Fit is a program to manage better vestibular migraine. I cannot advertise for it because I don't know exactly what's in there. but I've heard some good comments about it, and it's definitely worth investigating. So those are good resources for you guys. And I think that if I can give you a bit of a note of hope, is that there are things that can help you out there. And as with all my patients, I recommend a holistic approach, incorporating everything from exercise, breathing, medications, optimal management. So my conclusion, well, I hope I've shown you that the vestibular system, which is bugging us, obviously, and I'm definitely suffering from my vestibular system, but it is fascinating. Definitions are evolving. Vestibular migraine is disabling. I think we should think in terms of networks and instead of names. I mean, we need names and diagnoses, but I think just keep in mind the complexity of those systems and move away from a kind of a all or nothing, black and white, it is this or it is that. Usually it is a mix of many things. Vestibular physio may not be the key. It might be worth it though. Anxiety management, extremely important if you live with VM. Trial and error is still the best approach. There is growing evidence for Botox and CGRP blockade. I haven't shown you studies, but there are studies. And triple PD is probably a part of the problem for at least some people with vestibular migraine, and it can be addressed also by proper therapy.